you are, it's 12 o'clock. You are at MiHIN's The Download. This is a monthly webinar diving into the intersection of healthcare and technology. Thank you so much for being here. So first of all, we're going to get into this. This slide has a lot of stuff on it. But what I would like to impress upon you here is that I am coming from a place where I am going to sort of make it known to you that the way that I see our work. My name is, so we'll come back to this one actually. Kate, let's go to the next. This is our agenda. My name is Joanne Jarvie. I've got the whole thing today. I am the Senior Director of Outreach and Market Communications. You may have seen on that big slide, you know, the big words were neutral data steward and nonprofit and connecting disparate sectors. And what I work in, the reason why I work at MiHIN is because I have found that technology is actually easy. As compared to humans, because, well, technological infrastructure can be coded for, and human infrastructure can't be coded for, and it's where the stuff is. When we talk about how we communicate, how do we get information from one person to another person, or from a sender to a receiver, we talk about it in all kinds of different ways. Sometimes we call it data. Sometimes we call it information. And I think there is tension around all of it. When we're talking about data, are we talking about what type of data? How much data? Data for now? Data for later? Data for one person? Data for a certain group of people? Data for a state? And so we use these terms, data and information, health information, and we use them interchangeably. And it's because not doing so would take a lot of time here. But also you will see that MiHIN has tried to solve for these tensions. So thank you for coming today. I want to make sure, first and foremost, that look, if you're not hearing what you came here to hear, interrupt me. Put it in the chat. I want this to be as valuable to you as possible. I want to know why you're here. I want to know why 220 people signed up for this. And I want to make sure that I'm delivering for you. The way that I'm planning on explaining MiHIN and what we do is I will be using something that I learned from MPHI through a grant by MHEF, that's Michigan Health Endowment Fund, and Michigan Public Health Institute, our partners in this work, is sort of, I'm going to start with the why. And then I'm going to look at the who, for who, by who, with who. I'm going to move through to the how, and I'm going to finish with the what. So you may find that today will be lighter on the how and lighter on the what, which that's what people want to get to, right? Well, too bad we have to start with the why, and we have to make sure we talk about the who. And then over the course of this year, through the download and our accompanying convening called Bits and Bytes, we are going to dig in deeper to the how and the what. And all along the way, as we learn, we should be implementing feedback. We should be responding to each other, and certainly I am praying and hoping for your engagement. Let's challenge each other. Let's please make sure to be respectful, and let's get on our way. So hold on one second. I'm going to go off screen because I've got something to read, and then I get like nervous looking at myself. So I will be off screen, but I will be talking, and I am here. And somebody will be also looking at the chat, so no worries, you won't get lost. Also, don't forget to interrupt. I like it. Okay. So hold on. I'm going to stop my video, and I am going to start with our why. So this chart comes from Gartner, which is a technological research and consulting firm. Gartner defines data for good as a movement in which people and organizations transcend organizational boundaries to use data to improve society. And I think this is a pretty cool, image. If you're looking for a why, if you need a why to wake up and do good work, maybe one of your whys is on this chart. Our why is so that we can create an infrastructure to transcend organizational boundaries so that they can use data to improve our society. MiHIN and health information exchange networks evolved as a solution to data silos that emerged among hospitals and health systems and the variety of electronic health record software they implemented. We evolved as a solution so that we could provide a shared, necessary technology and infrastructure for the secure, private, legal, digital exchange of clinical data to help improve the health of Michigan's people. Next slide, please. What's important here to note is that with MiHIN, Michigan has established a nonprofit serving as backbone infrastructure for a successful data exchange framework that equitably meets state and stakeholder goals. So we receive health information from a wide range of providers, labs, pharmacies, health plans, and other community stakeholders. We are responsible to match it to the appropriate person across all those disparate source systems to monitor not only who needs that information, but also who's authorized to access it, and then to provide it securely and privately to authorized users. So, in addition to the technical necessity, yes, we are a technical infrastructure. I want to impress upon you that having a collaboratively governed, neutral steward of data is critical in these times. There are other kinds of organizations that can technically exchange data, including national networks used primarily by large health systems with bigger and often most costly EHRs. These networks are provider-centric, and they do have their limitations. They do not support real-time event notifications, we'll get into that later, that providers need to better treat their patients and parents, gosh, those parents. Health plans do not participate in them, and smaller providers and community-based organizations that don't have the budget or the EHRs to connect to them are often left out. By most estimates, there are more than 500 ambulatory EHR vendors in the market. Next slide. Inefficient care delivery, when doctors don't talk to each other, results in $130 billion in wasteful spending every year. As a result of inefficient care delivery systems, patients receive repetitive tests and/or health complications, reduced functional capacities, and often require further medical care in the future. Nationally, an estimated 251,454 people die annually from medical errors. And when you adjust that for Michigan, that's about 7,768 people over a year, which is 8 times more people than die from car crashes. Many medical errors are caused by administrative complexity and exacerbated by problems with health information technology. Waste in the forms of excessive and redundant administrative burden, HIT usability, interoperability deficiencies, failures of care delivery, including care coordination, over and under treatment, pricing failures, and fraud account for at least 20% of total healthcare costs. So in other words, an estimated $19.8 billion a year, or approximately 4.7% of Michigan's state domestic product, could probably be utilized more efficiently. And that is what we're going for. Next slide, please. So We were created to solve for a lack of coordinated care and inefficient systems. Our why is to create streamlined delivery of care to improve health outcomes. Governments, civil society, and industries are just beginning to understand the value to society in much the same way, value of data to society in much the same way they considered the importance of thoroughfares 200 years ago. Next slide, please. But the superhighway of anything isn't without its hazards. Unless careful planning occurs, as happened with the US interstate system. When building began on the interstate system in 1956, the death rate per 1 million miles driven was 6.28. Today, that figure is 1.46 deaths per 1 million miles, a testament to diligent efforts to build continually safer highways, design safer cars, adopt speed limits, and provide ongoing oversight. Just as these roads, just as power lines ushered in a new era of physical infrastructure and energy that has helped society thrive, investment, time, energy, collaboration is needed to support modern approaches to our data infrastructure in order to enhance economic growth and innovation, but really to just support individual health and wellness and to protect us all from harm. No matter your organization, the opportunity to create a more responsible tech future is massive. For technology to truly work in the public interest, we need to invest in those organizations that are building free from corporate profit motives and that respect and work to integrate, incentivize, compensate, and coordinate disparate sectors with whom they work. Next slide, please. This is a representation of the MiHIN network, which we like to describe as a statewide digital fabric of trust. So we've moved from our why to our who. Before I move on to the who, does anybody have any questions or statements or suggestions about the why of health information exchange, the why of MiHIN today in Michigan? All right, let's keep going. Okay, so next slide. For whom, with whom, by whom? Who does MiHIN consider a stakeholder? Well, let me give you a definition of a stakeholder. A stakeholder is a party that has an interest in a company and can either affect or be affected by its business. MiHIN's stakeholders are healthcare stakeholders. They are the people in Michigan. And you'll see at the bottom here, you're looking at this micro level. The micro level here is people and their families, anyone who is a patient, directly as we roll out consent and increasingly get data out to people related to public health support. In the future, as social determinants data is tracked, we will do more virtual care, more screening. Moving up to health professionals. We do what we do for physicians, for nurse practitioners, for physician assistants, for nurses, for respiratory therapists, for dentists, for pharmacists, for occupational therapists, physical and behavioral therapists, as well as allied health professionals, such as phlebotomists, medical laboratory scientists, dietitians, and social workers. We do this for our hospitals, for our long-term care facilities, and our emergency departments. We do this for the Michigan Department of Health and Human Services, our main customer today. Other state agencies like the Department of Corrections, Departments of Licensing and Regulatory Affairs, the Department of Education will become increasingly important, and so will cross-sector data exchange. Insurance companies, organizations like prepaid health insurance plans, PIPs, Priority Health, Blue Cross Blue Shield, Medicaid managed care plans, prepaid inpatient health plans, there they are. They all connect to our network. Counties and cities, as we do more with the communities, county communities, county government, such as public health, but also emergency medical services and county jails are important. Similarly, the continued work with city governments like Detroit or Grand Rapids, for example, connecting county jails, working with city public health departments, local social workers, foster care. Again, as recognition around social determinant of health, the necessity deepens, the necessity for health equity and the honoring of patient choices grows. And then so do healthcare stakeholders. Healthcare now extends to cities, counties, and community service organizations, and all of the other social service organizations that are providing care to people, inclusive of interfaith organizations. Next slide, please. So as we look at this slide, I wanted to try and work sort of, so I showed you before how we go from macro to meso to micro, right? And through all of those sort of levels, a health information exchange sits sort of in the middle as a layer, as an interoperability partner. And you can see here that moving from environment, so regulatory and market and policy framework, through organizations like hospitals, through a care team, truly to a patient, is what MiHIN has been designing for. So the value of an information exchange, a health information exchange, cannot be defined solely in terms of benefits accrued to just providers or just policymakers or just payers. The value of HIE can't be parceled out in this fashion. It must be considered in terms of benefit to all participants in the healthcare system. And it requires deep collaboration amongst competitors, frankly. And the healthcare industry has had some difficulty with this prospect. Other equally competitive industries have managed to survive and thrive with interoperable information exchange. MiHIN, next slide, please, has designed its core functionality in its active care relationship service to be patient-centered, to be able to provide information that is important about the patient, to provide context about the patient, not just data, not just information, but context, a story. Next slide, please. Okay, I am going back here. So this is sort of like a history, but it does take into account the who, and it's really important. So to set priorities for the state and to provide for a degree of oversight, Michigan legislators created a Health IT Commission with members appointed by the governor. The commission's recommendation led the Department of Health and Human Services to select MiHIN as the state designated entity for health information exchange. This model seeks a careful balance between state government input and private enterprise. MiHIN appoints a board member from each of Medicaid, the Department of Public Health, and the Health IT Commission. This approach relies on governance rather than regulation to ensure patient privacy is protected and that the health information exchange is operating in a trustworthy manner. So the state promoted the early growth of HIEs by encouraging local organizations to form throughout the state. You can move forward in the slides. Let's see here. Maybe we can. All right, there's our governance structure. So remember, there is the Health IT Commission. There is our governance, there is our Operation Governance Advisory Committee on which stakeholders sit. They report up through executive leadership who reports up to the board, all the while interfacing with the Michigan Health IT Commission. So next slide. The state, so this is sort of our hub and spoke model, and it shows what, let's just say, what digital lines, right? What connections would need to continually be established, protected, updated, reestablished, standardized over and over and over again between each different stakeholder, versus, just doing it once through an HIE network. This is called a network of networks model. This is called the hub and spoke model. And this is to illustrate money savings. This is to illustrate the lack of duplication. This is to illustrate a simpler, easier, more efficient way of sharing health information. Next slide. Okay, so the state promoted the early growth of HIEs by encouraging local organizations to form throughout the state. 9 HIEs operated in various medical trading areas with an assumption that competition would lead to innovation and consolidation. Next slide. Michigan subsequently formalized MiHIN, nonprofit organization, as the state-designated health information exchange to coordinate amongst these medical trading areas. Having started by orchestrating small regional HIEs, Michigan today engages with MiHIN as a consolidated statewide public-private partnership. Next slide. For Michigan, it's a careful balance, again, of state engagement and private enterprise, starting with many small HIEs and evolving to one, which has produced an infrastructure which I'll describe today as capable and innovative. Next slide. Okay, how does it work? By sending and receiving patient health information from many different EHRs, primary care practices, emergency departments, pharmacies, health insurance companies, public health programs can all access and share critical health data in real time. MiHIN operates as an information hub that can send, again, receive, help our stakeholders find and use clinical data from a range of EHRs used by different hospitals, different clinics, other healthcare providers, other payers. The more EHRs that are connected to an HIE, the more providers that are connected to MiHIN, the more different providers that are connected to MiHIN, the more information everyone will be able to access, creating greater value for all participants. The collection of data can also offer insights into population-wide health trends for greater public health awareness, more effective health monitoring, and resource allocation. Next slide. Rather than making technology the starting point, Michigan's approach to health information exchange focuses on the purposes for which data will be exchanged, or the whys. We also call these, next slide, please. This is our chain of trust, super important. We can go back to it. But stay there for a second, Kate, sorry. Our chain of trust is how we work under HIPAA. Does anybody have questions about this? No? Great. Our privacy officer is coming at the end, hopefully, if you do. Next slide. Okay, so we're on the how, right? And we're focusing on sort of how we try to start for the purposes, at the purposes for which data will be exchanged. Trying to understand the why, the policies, the incentives on a case-by-case basis. In Michigan, Healthcare providers are financially incentivized by health plans to contribute data on a use case by use case basis. The goal is to achieve a shared understanding of activities that the infrastructure must support, including defining the value, the benefit, and the priority of each activity. Next slide. The MiHIN Use Case Factory fosters and motivates the statewide alignment to advance a portfolio of use cases that employ national interoperability standards. The purpose of each use case is to help ensure that the right services and activities emerge statewide that lead to reducing complexity and ensuring fewer errors in confidential ways that generate greater customer service to multiple MiHIN stakeholders. The Use Case Factory is a formal methodology to modularize, prioritize, define, and advance data sharing on a large scale. It consists of a standardized approach to manage the full life cycle of a portfolio of data sharing scenarios or use cases, and the associated governance process to prioritize and motivate their adoption. So let's move through these slides. Now, I will say that our next download will be focused more deeply on the Use Case Factory, if that's interesting to you. I have here the 4 phases of our use cases and the use cases that are actually considered to be within each phase. And we can move through these as you like. We start with concept. And this is an idea with a sponsor, and with each phase, there are certain activities that we participate in to move a use case from conceptual to, next slide, planning and development, to, next slide, implementation, to adoption. Okay, so let's go back here. So a nonprofit, as many of you are all very aware, needs enterprising spirit and strategies for sustainability. Through affiliation and related companies, MiHIN is part of a growing multi-state HIE model. The team offers consulting to out-of-state HIEs and prepares scores and scores of interns every year to work in the health IT field post-graduation. MiHIN makes money using a diversified revenue model. We get paid by our stakeholders for some of our solutions and some of our services. This is because other organizations generally derive value from provider sharing, and because in many cases, small provider offices have limited resources. Typically, health plans pay us for subscriptions to use cases and some key services. Some health plans have even begun to purchase our solutions. The state of Michigan subscribes to use cases, services, and solutions, but also engages MiHIN for a variety of other projects. All right, and here we are moving into the what. MiHIN will always offer a solution that promotes the use of our services and data flows. We will send the data to any vendor that a provider in our state asks us to send it to. We have the use cases, which belie our services. And in order to be able to extract the data or to see the data or to get the information, we have also created some solutions that you can use to get at the information you need. This is a list of our services as they stand today. Followed by our solutions. Next slide. I wanted to also, when we talk about the what I often I get lost sort of in the scale of all of this stuff, we have to work with an average of about 7.5 million ADTs in and 11.5 ADTs out, which means that when we find an active care relationship, we typically find more than one, which is exactly why we were created. The same is true of medication reconciliation. We have over 2 million labs flowing inbound to MiHIN. And again, more than one outbound per one inbound applies. Forecasts, we have forecasts that in 2023, we will hit a cumulative total of 10 billion messages. We went up 1.6 billion in a year from 2021 to 2022. So this is an infrastructure designed to scale. It's designed to be statewide. Next slide. There are many areas of opportunity, folks. The areas of opportunity for MiHIN come from a variety of sources. Mostly they come back from our stakeholders. We have been named a lead entity for Michigan Health Information Technology Commission's 5-year roadmap, A Bridge to Better Health. And in that plan is, our timelines to support and reduce health disparities, to maximize public-private partnerships, to support systems that address social determinants of health, to expand real-time notification and data exchange, to enhance the use of data, to measure performance and drive decision-making, and to streamline these activities across the system. Adopting a build once mindset. These are your pipes. How do you want to use them? Please don't build again. Next slide. Besides just looking at what our Michigan stakeholders are telling us, what they need, what they value, where they want to go, we also take direction from the ONC and from CMS rules. You will see that over the next couple of years, there will be, some standards that have to get into place. There will be some FHIR adoption that our government is going to look to providers to sort of get up on. And MiHIN is really hoping that we can be your valued partner in like carrying the load here. We believe that the infrastructure we have built will be able to take over and provide you all capacity to meet provider adoption, to meet transparency in coverage, shoppable service tools, and access APIs and prior auth. This is what we've been building for. Next slide. So it wasn't long and it wasn't too detailed because frankly, I want you to come back. I want you to come to our bits and bytes. I want you to learn more about our use cases. I want you to learn more about what services might be valuable to you. What services might be valuable to compliance? What services might be valuable to IT? What about the clinicians? What about your business bottom lines? What about your patients and your clients? We would like for our stakeholders to continue to engage so that we can figure out what information do you need to be successful? However you define that in your role, in your organization, what data do you need to share? What will it be used for? Is there a policy or a governance challenge or a way to use the pipes that have been established over the past 12 years to help you meet your goals. These are for public benefit. And we are here to open them up. I wonder if anybody has any specific questions. I have all of my account managers on here. I have a lot of partners. I'm seeing a lot of old friends. Are there any limitations on the EHRs used? Are there some that MiHIN cannot handle? So that's kind of an interesting, like the way that you put it, right? Cannot handle. Katie Olds or anybody who's here to back me up, my understanding is that MiHIN aims to work with every EHR, and how we work with every EHR is different depending on the EHR. Steph, anybody got my back? Anybody want to say it any differently? Megan?
No, you're absolutely right.
So when you say handle, I wonder what you mean by handle, Mark. I think one of the...
I think where Mark might be going, and correct me if I'm wrong, because I'm making an assumption here, that there are some EMRs that we don't work with. Some are much easier than a couple others to work with. So one that I'm hearing quite a bit lately that we don't work with would be Practice Fusion. We do not currently work with Practice Fusion because of the way that their cost structure is set up. There's a lot of gray area there that I think kind of puts not only MiHIN in a predicament, but also the external.
What do you mean by external?
It's just the way that the cost structure is set up, that there's some weird, I don't want to get into the weeds in this call. Let's just blame the cost structure. And I'm seeing questions also come through. We are working with eClinicalWorks. They're a vendor that is probably maybe a little bit more complicated to work with, as opposed to somebody like an Epic, but it doesn't mean that we're not able to work with them. So if we do receive a request to an account management team, just let us know which EMR vendor you're working with, and we might say, yeah, we've been working closely with them for years, right? Or we can tell you, yep, we can work with you, but here's some things that you might have to be aware of, or here's some questions that you might have to ask your vendor initially. So we try to help with all the information up front to make sure that you're all having the conversations that you need with your specific vendors.
Brandon, I see your chat here. Your org would benefit from useful dashboards that would group all the info that we can pull from My Gateway and or other programs. So I'm trying to read between the lines there. I am thinking, so if you want something so that you can join the data that you get from My Gateway with all of your other solutions, or can you, right? Well, I have some news. It's not like major news because, I only understand the technical things like this much, but I hope that all of you have now heard that MiHIN is underway for a pretty huge technical migration. And the reason for that technical migration, well, there's a couple reasons. Number one is technical debt. Number two is, and maybe most important, and to your point, with FHIR, F-H-I-R, there will be so many different ways of being able to extract the bits of data that you are looking for and get it into the places that you want it. So we believe that with new FHIR apps and with our new FHIR supported cloud infrastructure, there will be a time when you can move data from your different solutions and sort of put it together in a place where you can make sense of it. Let's see here. I hope that helps. I don't think right now we can, well, I mean, if you're using Acres, you should be able to pull up all of your active care relationships in My Gateway. And group the information. But maybe you're looking for more or better or deeper. Brandon, I'm still on you. Mike Taylor, you put a whole thing in the chat when you're like the best guy and everybody wants to see you. You were saying that perhaps a clarification could be that MiHIN isn't one app that is or isn't compatible with an EHR. We move data based on how an EHR can import and export. And then when it comes to our solutions, we design based on interoperability standards. There are EHRs that don't natively support certain use cases.
Without customization.
Without customization. Are there EHRs that work best with MiHIN for interoperability and usefulness to organizations? I haven't heard that there is any EHR that works best or doesn't work best. What are the opportunities for researchers? Can data be requested for a research project? Can I think of MiHIN also as a data warehouse? No, I wouldn't think of MiHIN as a data warehouse. And I know that in the future, we are really looking to make sure that we can impact research opportunities and get even closer to precision medicine and pharmacogenetics. But the opportunities for researchers, I believe it's like a different, is Shreya here? Is anybody from our legal team here? I think that it's a different, so I think that we would have to create different use cases specifically for research, if that makes sense.
The other thing I'd like, this is Crystal Schramm,
Hi.
Senior Technical Business Analyst at MiHIN. I think the other way to look at it from the research perspective is to think about the more data that the healthcare entities are able to receive on their part, the more that they will be able to get into those research programs on their side, because they're going to have that first source data. I mean, we're really that secondary source. We're the pass-through. So that's important to remember. We're not, we can act and do functions like a data warehouse, but we're not really a data warehouse. We have the ability to store data, but we store it so we can transmit it to facilities. So like Joanne was saying, yes, there are opportunities for new use cases that could be specific to certain research areas or subjects. But I think from the larger picture, it's more important to us to think about that indirect role of making sure the healthcare entities get the data, because I do think this is really the first step in affecting the data that we will be able to do with future research, because we're able to get it to the people that need it for those purposes.
Thanks, Crystal. That was really helpful. Is there anybody on this call that had no idea that a health information exchange existed? I had no idea that this existed like 3 years ago. And when I found out, I like my mind was blown open, and then I bullied them into hiring me. I find that the existence of a collaboratively governed nonprofit neutral steward of data, digital infrastructure, to be like what every sector needs. So I think that, healthcare actually is doing something right here, and that other sectors can learn. Did anybody have any specific questions about or suggestions for what they want to learn more about, like how to use the data that we can exchange, or what's working, what's not working? Our next, like I said, our next download will be a deeper dive into our use case factory, followed by a bits and bytes sort of going into ADTs. kind of where it all started. Do we have anybody representing community-based organizations or social service providers here today? Hi, Jared. Wait, hold on one second, Jared. Brian, our data does not interface with homeless services, HMIS. Our recuperative shelter has data sharing limitations that we had hoped could be assisted with this data exchange. Is there any chance that your data exchange can include that? Well, Brian, I would like to say that I believe that there are a couple of different sort of task forces and programs that are looking to create cross-sector data exchange between a platform like HMIS and MiHIN. So when you say our data doesn't interface, Brian, do you guys receive admit, discharge, transfer notifications? Like, do you know when your client, you do? Okay. So how do you get those? You get those by fax. Well, I mean, do we have people on? I don't know why you're getting them by fax.
He said he's from homeless services, correct?
Right.
So it's possible that with a community-based information or a community-based organization that they don't have that ability yet. And like you said, that's why we have that statewide community-based task force that's right now that's literally working on developing data exchange for community-based services to be able to send and receive data. So Brian, so your particular scenario would fall right into why they are having those discussions right now. So
right.
That's
also,
a great example.
I mean, so yes, ADTs. But they already get ADTs, Crystal. They just get them by fax.
Yeah, I'd have to dig into more into this one.
Okay, so Brian, so remember I'm getting like, oh my God, you guys, I'm so excited. I have to take off my sweater. There is this Michigan Health Information Technology Commission. Remember that I talked to you about. They helped to create MiHIN. They are part of our governance structure, and they have started a CIE task force. Community Information Exchange Task Force. And on that task force, I believe are organizations or entities that are hoping to be able to connect more community-based organizations throughout the state to get the data that they need. And I think more and more, you may be asking, well, like, what data can we get? Can we learn when our clients have been admitted, discharged or transferred? Would we be able to see what medications they're on? Would we be able to, what information is useful? And where in the trust framework of HIPAA do you fall? And then, which is all human infrastructure, basically. It's not even technical infrastructure. HMIS, I feel like, is run by WellSky. WellSky's sitting on one of our community of practices, trying to figure out how to create interoperable referrals. So I'm thrilled that you're here. And I would love for the people on this call to note that what we're working on is what is needed. A joint venture, West Michigan Cancer Center, a joint venture between Bronson and Ascension. So Jared, you're probably covered under Ascension then at the West Michigan Cancer Center. Do you receive information, health and no Bronson under Bronson and on Epic? Well, what about Bronson, Meg? Do we know about Bronson?
I'm sorry, Joanne, I missed the initial question.
Bronson is part of our network, right?
Yes, absolutely.
Okay. So I have a guy here, Jared. He is part of, on getting results. We have a current ticket. Look it up. Jared Adams from the West Michigan Cancer Center. We ghosted you? Is that?
Yes,
what you-
I'm aware of the ticket. We're not ghosting you. You are looking to get results delivery. Is that what you said, Jared?
Results. He said getting results.
Okay. Yeah, I know there's some open communication going back and forth. So let me look at the ticket and we'll see where we're at and I will reach out to you after this call. How does that sound?
Jared, that's to me, that sounds great. But also, look, if you feel like you're getting ghosted, you should come to me because I'm like a stalker. I've been ghosted so many times, I'm like traumatized. I won't let anybody get away with that.
Joanne, this is Megan. I also might want to add that when we do receive initial tickets to our ticketing queue, the account managers respond in a comment within that ticket. So sometimes we know that there are security issues from an external side that may block automated emails from Jira, which means they could have been in your junk folder. They could be held up somewhere in your system. So one recommendation that I have is that just checking with your security team to make sure that you can receive emails from Jira. It's a no reply email. But I also want to note that if the account manager doesn't hear from you within, 2 to 3 business days upon reaching out through Jira, we're calling you, we're emailing you. So we're reaching out to you outside of Jira in case there is that security layer there. So I just want to put it out there that if you don't get initial response, that could be one of the reasons why, because I am on my team like hotcakes to make sure that they're responding to you all in a reasonable manner.
Thanks, Megan. So we got all the account managers on here, folks. Jane, you own and operate a primary care clinic, and you've used MiHIN services and solutions for years. How wonderful. How else can we help? Are you guys doing SDOH screenings? I don't know.
Yes, we are.
Yeah.
We do not use you for that.
So
Probably
okay.
should.
But hold on one second. So that's fine. You can use, are you using a platform for the screening and assessment?
Yes, we built it into our EMR.
Great.
Yeah.
And then are you guys able to, because NCQA has put in a new SDOH measure. And there is an SDOH use case where MiHIN can take in SDOH screening data and share it with other care team members. It doesn't matter. I mean, you should or could be using any other platform.
Okay. So then it would just be an issue of mapping.
Right.
Okay. That sounds good.
Yeah. And what else? What haven't I covered? Did I answer people's questions, or do you have deeper questions? Do you want to email me? What next time can I share with you? Any suggestions? Is anybody here not connected to the MiHIN network and interested in learning more?
This is Jane again. One thing that I think would be helpful is we have a patient family advisory council, and we have discussions about privacy.
Yes.
And how they, helping our patients and their families think through those issues in ways that seem manageable. The whole topic seems overwhelming to them. And yet it's frightening to them how accessible their data is.
So, right. I think so. It's interesting because as we move, the digital health literacy in general is, is just, it's not widespread. And it needs to be on everybody's list of most important things. I'm attaching our consumer privacy policy, Jane, in this link here. But when you are discussing the sharing of health information with your clients, does it start with HIPAA? Like, does it start with what they consented to or what they don't even have to consent to?
Yes.
Okay.
Yeah.
Okay.
Mhm.
And then do they ever get to so is it more just about, like, do you talk to them specifically about a health information exchange?
Yes, because it's a smaller group, it's a council group. They're to advise us about how to communicate with the bigger group.
Okay, so we have been creating sort of things that we are hoping can be more like consumer facing to try and manage some of these questions. They're coming up at schools, they're coming up, parents are coming up, it's coming up in the news. And so I wonder if I can follow up with you and see if any of what we're creating might be helpful.
I'd love that.
Cool, I'll workshop it with you because we do have a couple of different like ways that we get at what we do depending on like the level of health literacy. And it would be so helpful to hear your feedback and your council's feedback.
Thank you.
We have 2 minutes left. Yeah, anything coming new on the horizon for MiHIN as far as use cases? We are thinking about, we've been approached to look at something called an alert and query use case, which would be able to help us show really important information to emergency room care providers, but also to sort of use our active care relationships to understand what information is important to you, and then to go look for it, grab it, and then bring it back to you, alert and query. So that's one. There is another one coming up, precision medicine. And we are also looking at remote patient monitoring. If any of these are interesting to you, please let me know. Of course, we're always looking for better ways to make the data that is flowing through the network more useful. I think for the past, 13 years, 12 years, we just wanted to see it moving. And now that it's moving to the tune of billions, it's also our job to make it transformative. How do we use what information or data you are getting to make you successful? That's just going to constantly be our question. Hi, Bill. Let me know. Seeking engagement with CBOs that are focused on SDOH. There are a lot of them. In fact, our partners at the state of Michigan are having an SDOH symposium, Bill Quinn, this whole week. Not sure if you've heard about it, but we can certainly talk to you about how we work with community-based organizations and how we'd like to start working more deeply with them and with the vendors that they choose as their social care platforms. Thanks, everybody. Please come back next month and the month after and the month after.
Thank you.
Thank you so much.